Hello, folks. Thanks for joining us on Head Inside Mental Health, featuring conversations about mental health and substance use treatment and co occurring disorders with experts from across the country sharing their thoughts, insights, and practice perspectives on the world of behavioral health care. Broadcasting on WPVM 1037, the voice of Asheville, independent, commercial free radio. I'm Todd Weatherly, your host. Your therapeutic consultant and behavioral health expert. Today, I have the privilege of being joined by Dr. Wendy Oliver-Pyatt, founder of multiple eating disorder and mental health treatment centers across the country, including Within Health, Galen Hope, Oliver-Pyatt Centers, Clementine, Embrace Treatment Program for Binge Eating Disorder, and the Center for Hope of the Sierras. Dr. Oliver-Pyatt completed her training as a psychiatrist at NYU Bellevue Hospital. That is a place to get trained, where
It
she
was
served
fun.
as, right, where she served as a chief resident. Her training and experience involved direct patient care and leadership across multiple levels of care and treatment modalities, including inpatient psychiatry, residential addiction programs, PAC teams, emergency room psychiatry, and public and private outpatient care. In 2001, she became the state of Nevada Division of Mental Health and Disability Services medical director. There's no small feat there. The first woman and the youngest person ever to be in the role, receiving senatorial recognition. In 2003, Dr. Oliver-Pyatt founded her first residential eating disorder treatment program, the Center for Hope of the Sierras. Later in 2008, she went on to found Oliver-Pyatt Center and Clementine, both nationally and internationally recognized top programs in their field of eating disorders. She authored Questions and Answers on Binge Eating Disorder, a guide for clinicians, and named by USA Today as a top healthcare entrepreneur 2024 and beyond. Recently elected as a fellow of the American Psychiatric Association. Congratulations.
Thank
Wendy
you.
carries her work with an unwavering belief in compassion and scientifically sound treatment. I also know her as just kind of a cool lady that I like hanging out with,
Thank
who
you.
I send very difficult clients to, and she says, yes, thank you.
hmm
Dr. Oliver-Pyatt. Wendy, thank you, and welcome to the show.
Oh, thank you so much, Todd. I really am so happy that you invited me. I look forward to our conversation and continuing to spend more time with you.
Absolutely. Well, we kind of we hit a little bit beforehand, right? But the I when we place the individuals and the families that we work with, it's very often that there's a very significant presenting eating disorder for the clients that suffer from that we end up calling it a co-occurring condition because we know that behind it is this very significant primary mental health condition that they are struggling with. Might be
Absolutely.
bipolar disorder, maybe it's borderline personality disorder or other personality disorder kind of features,
Yeah.
uh, and and that makes them very challenging behaviorally to deal with.
Yes, absolutely.
So we work with you and your centers, and specifically down there in Galen Hope, we've had several clients go down there because when a person is struggling with both conditions, you actually have both tracks at your center there and do a job that many kind of neglect, which is they do really good at the eating disorder side, but they're not paying the kind of attention that we need to pay to the mental health side. And you and the programs that you've created do an exceptional job of kind of bringing that art and science together. What brought you to that? I mean, you've got this distinguished career, and a lot of it's like public sector,
hmm
private sector, and you've just got to see the kind of gaps and failings that happened in both of those
I
systems and then
have.
brought
I'm
that
remembering.
experience and like created something. Where Tell me how you got there, please. Like what is it that like, hey, we got to do this better and brought you to the
Yeah.
place where you are now?
Oh, Todd, thank you so much for all those kind words and generous thoughts. How did I get here? I mean, sometimes people kind of talk with me and they figure, oh, did you have this planned out? Did you know you wanted to be an eating disorder psychiatrist? Because I did have an eating disorder early in my life. And so people think, oh, did you become a psychiatrist because you wanted to treat eating disorders and all that? Absolutely not. I had no preconceived notion, of my plan here. I didn't really have a plan. I think one of the things that I try to tell my patients too is that if we get in touch with our authentic self and we are like more organic about how we let our life unfold rather than feel like we have to have some exact plan of what we're going to do. A lot of times the path we get on can be much more anchored in like our soul and what really drives us or excites us or that we feel passionate about. I've been incredibly lucky because I I love what I do first and foremost, and that's kind of how the process unfolded. For me, my first love in going into psychiatry was really a fascination with the mind and a commitment to helping those with severe mental illnesses. That was why I did my residency at NYU. I really wanted to focus on community mental health. And through that experience, I had really extensive training on, the full gamut of psychiatric conditions and how we treat them. And I'm very lucky as well because even though at NYU it wasn't necessarily thought out this way, but it was an interesting blend of community psychiatry and also many of our supervisors were psychodynamic oriented Freudian analysts, believe it or not. So I got a
Back in the
little
day,
back
right?
in the day, that's kind of who they had as our supervisors. So I had this incredible mix. And I believe like I first, kind of fell into doing the higher level of care work really out of my own like frustration with like what I was being expected to do as a psychiatrist, which was sort of become a prescription pad. Because the field of psychiatry sort of got marginalized into, oh, you write the medication orders and everybody else does the therapy. And what I saw is just a lot of like bifurcated healthcare, like mental health over here and medication over here and therapy over there and medical conditions over here and even the medical conditions. So
Right.
people are this one, we're one human being and we have a multitude of different things happening with us. And the care itself being so fragmented just drove me absolutely nuts.
Well, in siloed care, the silos don't talk to one another. I get why
Exactly.
specialty has to exist, right? But and being in Bellevue, one of the one of the busiest psychiatric centers in the emergency psychiatric centers in the freaking country,
Yeah.
you're writing scripts and getting them out the door, right?
Yeah. But at the same time, I had these patients. I also got to do therapy and I had these analytic supervisors. So that was kind of the background, but I really just didn't want to become a prescription pad. And I just decided, like, if I'm going to do this work, I'm going to stick my neck out. That's when I started my first treatment center. I'm going to do it the way that I want to do it, which is not BSing, like truly integrated holistic care where there's a medical personnel, there's a psychiatrist that can do therapy, there's therapists, there's dietitians, there's recovery coaches, there's all of that in one place so that a person can truly be treated in this integrated fashion. So that was really, how it came about. And the field of eating disorders is very interesting because it's a really vivid example of probably the most vivid example of the importance of using that biopsychosocial model. And Hilda Brooke, who was one of the first clinicians to really write in contemporary times about anorexia nervosa, really revived that concept of the biopsychosocial foundation. It was already came about by another physician, but she kind of brought it into life with her writings about anorexia nervosa. And there really is, I mean, any disease process has a biopsychosocial foundation,
Hmm.
whether it's diabetes or lung cancer, heart failure, whatever, there's always that biopsychosocial piece. But in eating disorders, if you don't really pay attention to all, then you're not going to get anywhere. And also, the same is true for primary mental health. We do actually
Right.
treat primary mental health with or without the eating disorder. So, using that foundation is really the anchor to being sure that you're leaving no stone unturned and you're hitting all those domains of care. And you mentioned about how eating disorder treatment can be very focused on just the food and the eating and all of that. Well, that's a very behavioral thing, like eat the food, weight restore, blah blah blah. I believe that when you only focus on behavior and food, you really are hurting potentially the patient because the psychodynamics and the healing process like also has to happen. So I really believe that behavioral is important. Like it is important to put containment on behaviors and expectations and have very clear process there that's not punitive. It's natural
Yeah.
consequences. So the behavior, we don't go punitive, we go natural consequence. We can talk about that. But at the same time, we always lead with compassionate curiosity and a psychodynamic foundation. And so we really need to understand our patients in this psychodynamic way as well, and in a relational way, because it's the relationship where a lot of that healing is going to happen, and understanding the 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 trauma history, the psychodynamics within the family, psychosocial reality that the person's experiencing. If we don't also include that, then just changing behavior when a person's in a higher level of care will have no lasting impact.
Well, and soon as the behavior mod goes away, right? The modification mod, they're receiving support on eating, somebody's watching their calories for them, they're doing all these
Yeah.
things, and then they go out on the street
Yeah.
and all that goes away.
All of it goes away. It doesn't generalize. And also, if it's just punitive, it also just doesn't go. Like the patients, our patients or the clients, whatever you want to call it, I call them both, um, are intelligent people that understand, like are capable of understanding like the process. So if we explain to the person, this is exposure therapy, this is how it works, it's going to feel harder and then it's going to feel easier. You explain, I'm not just shoving you down this road for no reason. This is called exposure therapy, this is how it works. And we explain what's happening to the patient, and when we use natural consequences, right, we're helping the patient see and experience the ramifications of their behavior. We're not just putting a protocol in place. We're helping the person see, like, well, the reason you're not doing high cardio in our movement program right now is that you actually have orthostatic vital sign changes. So you're going to be dizzy, or your blood sugar has been really low. So, of course, we're not going to strain your
You're gonna
body
jump on a
further.
treadmill and it's gonna tank, yeah.
Yeah, so
Right.
we use this process of natural consequences, like, oh, you purged in the program. Like, we're probably not going to be okay with you going on a pass right now. And so things like this are very, very important. A lot of times, also, families don't understand how to implement this attuned care where there's the natural consequences. The natural consequences is akin to what Maria Montessori talks about, freedom and responsibility. I don't. My kids went to Montessori, and one of the most powerful kind of mock papers I read that they made you read like Montessori work was this concept that talked about freedom and responsibility being intertwined. Well, when we are gradual and attuned in what freedoms we give to our patients, that's tied to what they can responsibly manage, that actually imposes upon them the demand, if you will, to heal. And that is how we grow. It's really, honestly, it's common sense developmental
Yeah.
process.
Well, I mean, it's a parallel to experience, being an experiential ed nerd.
Mhm.
Wilderness approaches the same principle. It's
Oh,
like,
really? Tell me.
hey,
Yeah.
well, I mean, it's like, hey, it's raining. You might want to put a raincoat on, and if you don't put a raincoat on, you're gonna be wet. It's real simple. It gets real basic really quickly.
Yeah.
But like you say, it's informative. It's something that provides a person with education, but in addition to that, agency, where
Yeah.
they like, hey, I understand.
Agency.
That's right. I understand what's going on. I'm making choices because I know that there are consequences to my behavior. And consequences, they may be good, may be bad, but you're making active and engaged choices about what you do in your behavior so that you get the outcome that you want, right? But the thing that you're talking about here that interests me a lot as well, and I know that you're also a very experienced addictionologist, a person who understands addiction at its core principle. You've got individuals coming in there not only suffering from mental health disorders, eating disorders, but also substance misuse
Yeah.
disorder as well,
Absolutely.
and helping them manage those things. But the not being punitive,
Yeah.
because there's a lot of you've got this, let's call it a subsegment of the treatment community
Yeah.
that it's confrontive. Um, I don't know if we might go as far as to call it punitive, but it
Yeah.
kind of
It's
is,
like the whole concept that you're defective at your
right.
core. Yeah.
Or that you relapse, you got to get kicked out, like until you decide you can do something better. You don't
Yeah.
come back to us until you're ready, that kind
Yeah.
of thing.
Yeah.
And uh, I think that there are programs that are successful in this approach, and maybe they modify it or they use it in a different way.
Uh-huh.
What is your approach like? Give me the nitty gritty
The
of your
nitty-gritty there.
thoughts. Yeah, please.
Well, I think that I start with the premise that within the essence in all of us is this like whole person. And we want to, so I think we all kind of want to love. What do we want? We want to give love. We want to receive love. These are the things. We want to give love. We want to receive love, right?
Hmm.
We want to be accepted for who we are on some level, like who we are. Like we want to feel like we can be who we are. We may not consciously think that, but we're more at ease when we can be loved and connected with and be a part of some kind of culture or grouping where we are accepted for who we are.
Belong, right?
Yeah. And there is that part of us that has a need to manifest something about ourselves for which we are passionate or we are drawn to or whatever. Like we want to manifest some love, goodness. I think most of us are really, we're born into the world with these basic kind of aspects of our essence. I just called our essence. I think our essence of who we are is a beautiful, we're beautiful. We're beautiful little babies born into this world, and we just want to feel safe, protected, loved. So if we kind of start with like that's who each one of us really is at our core. And then things happen in life and we build defenses, or we have a medical condition or a psychiatric condition that gives us, barriers to manifesting that in a full way. We encounter trauma. A lot of things can happen to us that make us, more guarded or defended or unable to kind of just manifest what we're capable of manifesting. So whether it's SUD or mental health or eating disorder or whatever, I think if you kind of walk into the space with a patient believing that about the other human being sitting there before you, and also walking in with that humility of like, that the true one of the definitions of humility is like, I'm no better than, or worse than anybody else. Like we're on an equal playing field. I'm not some authoritative. I know, I
You've
mean,
got to
it's important
do
to have
right.
conviction about how somebody gets treatment, right? And saying, okay, I can guide you, let me hold your hand. But to say I'm a superior being to you in some way, shape, or form through your behavior, overt or covert, is really, I think, a shaming thing. So I don't really believe in shaming people into behavior. I think calling people out for behavior that's hurtful to others or short-sighted, like you can do that, in a loving way. So I think if we really use that same model of the biopsychosocial, whether it's SUD or not, and we're really doing good psychotherapy, I think that
Mm.
is really important. Conducting good psychotherapy, and whether it's SUD or whatever, it's if you're doing good psychotherapy, you're going to get into the essence of who that person is and helping them then manifest what they're capable of and giving them tools and supports along the way too. So in the case of SUD, there's a lot of times of co-occurring depression, trauma, anxiety, or whatever that makes it harder for the person to operate or function. So giving them supports and tools, sorry, a cat just jumped on my on
No worries.
my I told you before I have foster cats. So um but helping people manifest that essence, whatever their primary various conditions are. Within that, though, I think that when you're working with an SUD folks, like you really have to give consideration, and with eating disorders, what's their psychosocial experience going to be when they leave? Are they going to be in a kind of pro recovery environment? Like because
Mm.
I mean, really being conscientious about what's surrounding that person is very, very important when it comes to SUD, and helping them make choices where they're not going to get exposed to things that are triggering them or inviting them, or maybe they're in a toxic relationship, or maybe they're in an environment that's reinforcing the use of substance. So really, you have to be very practical with SUD. So I think that's also, and with eating disorder too, but that's one of the things I think, Todd, that comes into play. So getting into the underlying dynamics, the family dynamics, where there's sometimes intergenerational trauma, intergenerational SUD, and addictions and mental health problems that all played a part in the evolution of the various defense mechanisms a person may have, or adaptations to life, or the worldview, our cognitive scheme of like how do we see the world, or what do we expect out of relationships? I expect relationships to hurt, like I need to be defended against that, or whatever the schema may be. That's where the true, psychotherapy comes into play. So again, going back to the biopsychosocial piece, getting the medical piece sorted out. A lot of folks haven't been doing great self-care and
Right.
nutrition, getting that sorted out. And then last but not least, on the SUD side, there are some medications that a person can use that are helpful. I think, using something like antabuse is not, it's not unheard of. I think there's so much stigma around it, but it's a very helpful tool for folks with, or naltrexone or the various
Right.
ways that it can be delivered. So I think I mean, the research shows that these are underutilized tools as well. And so I think I just don't take that view of somebody being defective. I more take the view that they're struggling and they need healing, whatever the primary conditions really are.
Well, and I think that you're saying something that's really key here, and you're naming something else that is you haven't overtly said, but it's why the work that you're doing, I believe, is innovative and effective, and something that a lot of the world misses out on. Trying to bridge, how do we bridge this piece? But first of all, treating them like a human being,
Yeah.
and a whole
100%.
person, right?
Yeah.
They're not a number, they're not a script, they're
Yeah.
this person. We need to look at the whole scenario. But the other
Yeah.
piece is this long, like, where are they going to be a year from now? Or two
Exactly.
years from now? I've got to think about their life in a long-term scenario. And I think that that's the trap that the hospitalists, say, for example, can fall
Oh my
into.
God.
It's like, I don't know where this person's going now. I'm
Yeah.
going to script them as best I can to manage symptoms and hope that that works out. But the truth is
Exactly.
they're going out into an environment that's not very supportive. They fall over. You've been involved with PAC teams,
Yeah.
assertive community
Yeah.
treatment.
Yeah.
You've seen where it lands on the ground, where it falls over, where people run into their stumbling blocks and end up repeating the cycles and everything else. Some of your programming is also has got, PHP and IOP aspects of it, and you've done a lot of outpatient care. Where, for you, where does the rubber meet the road out there
Well, that's
after
really a good,
treatment? You know what I mean?
yeah,
After residential.
I mean, I really believe that the model that we generally have in our culture is flawed. And you're alluding to that. I think
Yeah,
there's
you think?
flawed. And so sadly and tragically, people who go into higher level of care and then struggle, they lose hope, they internalize shame, they hear that they're treatment refractory or treatment resistant. And what I say is like, are they treatment refractory or did they just not get good treatment? That's the question that we have to pose here, I think, because whether it's like they didn't get good psychiatric management, which you alluded to, they really have bipolar disorder. Nobody treated that. They really have trauma. They never had EMDR. They really have depression. They've only been on 20 milligrams of Prozac for 3 years or something like that.
They went to the
So
hospital, they put them on the velvet hammer and sent them out the door, and
yeah. So what happens, the model is, you mentioned this with the hospice, there's this model that, because we're cheap and we're a society that wants to get everything done fast. So it's like, oh my God, the person's symptomatic. Put them in a 24-hour care, put them in a hospital, glue them up to where they just, okay, they're not about to die tomorrow, right? Okay, they're
right.
not going to die tomorrow. Boom. There you
We've
go,
done our
back to
job.
outpatient. And even if you think about this is mind-boggling when you really think about the traditional model. Residential care being 24-hour care, PHP being 6 hours. So that model of residential to PHP is completely
It's
insane.
upside down.
It's insane. And so our model allows for a smooth transition from that 24-hour care, which right now we do it under the model of PHP with supported housing. We will have actual residential care as well because we've just recognized the need for that. But the 24-hour care, we can gradually taper down that clinical programming from 12 hours to 8 hours, et cetera. So we take a really serious look at patients before they go from 24-hour care to having the 8 hours or 6 hours of PHP, because that is when they are first, now they're out in the world on their own. So one of our little rules of thumb is that they don't move down to the lower level of care until they've demonstrate an ability to like manage that freedom. It's just like if your kid is learning to drive, I'm in Miami, we're just going down the street on 57th Avenue or something. I'm not going to be like, okay, we drove in the parking lot, here, go drive up, I-95 to,
Well,
you know,
Gen Xers, that's the way we did it. We decided that that was not a good way,
yeah, it's
right?
like, no, that's not going to work. So I think that this whole model is just flawed, this tapering down of care that's really attuned to where the person's at. And it's like, oh, they struggled a little bit. We moved them down to PHP 8. And now in that little window of time, they, drank or something like that. And then when you have the relationship, they can talk about the behavior too.
Right. They come to
You
you about
have,
it. Right.
yeah, they can tell you more about it. So I think that is really nice. And then also we keep that stable housing and the stable treatment team all through all those levels of care. So as they're moving around, that team is with them. They're not switching. They've got the same team. They still have a stable place to live all the way down to IOP. But you mentioned PACT. That's where this focus on acute care and then just turn your back on the patient in a sense at the IOP
Right.
level is so wrong. It's so flawed because people have to get integrated into the community. They have to have that life worth living. I mean, loneliness is a big issue for our folks. Like the Surgeon General named loneliness a big problem in our society. It is. Loneliness and having meaning, having a routine, we all need it. Look what happened to us when we lost our routine during COVID. Like the depression rates skyrocketed. I mean, for me, even working remotely, a lot of times, sometimes I'm like, I need to go in and be with my team in person.
Well, we run into this with our clients all the time as well, and to really say positive things about the kind of the model you're referring to, especially the treatment model that you designed down there, is uh, hey, I want to come out of this emergency level, this kind of 24-hour supervision level of care, and just go into outpatient without any supported housing, without any other components that are going into the support that I need. It's
Yeah.
like, so let me get this straight. You're going to come right out of this 24-hour environment. You're going to go spend, I don't know, 6 hours a day, 5 days a week, doing some intensive clinical work, and then you're going to go home to be alone at night. Are
It's insane, Todd.
you
Isn't it
kidding
insane?
me? You
Isn't it
know?
insane that we actually expect people to heal and do well in that model? And a lot of them don't even get that PHP. They might just go straight to outpatient or to IOP. And it's like, how can you expect somebody look, our patients are very complex. And by the time somebody makes the decision to go into 24-hour care, you know them because you're taking them, you're figuring out what to do to
Right.
them. Their lives are really in a state of major disarray. So they're coming to us with really serious things happening for them. And those things are not solved in 30 days in a 24-hour care
No.
setting by
Well,
any.
and your PHP, I mean, I think that to call it a PHP is almost a disservice because they're in
Thank
a
you.
supported housing. They've
Yeah.
got coaches with them all the time. They're in a highly structured environment. There's never really eyes off of them. So they're really in a what most would refer to as a residential treatment
They are.
environment,
Yeah,
even though there's some space that exists between where they live and where they get treatment. It's
exactly.
we refer to commonly the Florida model, right? It's like, well,
Yeah.
we want
And
to get the
that's just,
licensure and
yeah.
bill, but
Yeah. I mean, back in the day when I first started at like Center for Hope this year is we didn't need 24-hour nursing to be residential. That just kind of came into the field
mhm,
that residential needed 24-hour nursing. And honestly, that was an insurance company ploy to try to get rid of residential
managed
programs, to
care.
try to put them out of business. Because most people with eating disorders, some need 24-hour care, but most people at the residential don't need 24-hour nursing. They
Right.
need 24-hour monitoring and they may need nursing throughout the week, but it was really not something that it really wasn't something that actually made clinical sense. So, they needed the 24-hour monitoring more than anything. And that's what's so important to block the behaviors and give them the support. And then the tapering down and the building the connections in the community that's where that pact model comes to play.
So I got a question that I ask a lot of the folks that come on the
Uh-huh.
show that are doing innovative work in the private sector, have worked in the public sector, and the question I have is, what's the divide? Where do we bridge this gap?
Oh my
What do you
gosh, I'm
think?
so
Where
glad you
where do you think? How do we? Is there a
asked.
chance at it? Where do we start? Like, what's your answer to that?
I am so glad you asked this. Okay. Here I go.
Okay,
So,
get
okay,
ready.
so this is something that bothers me so much. Like, first of all, the first thing we're talking about here is the separation between acute care and then dropping people off. Of course, patients want to leave and they want to
Right.
be in the lowest level of care. That's normal, but So that's the first problem we have. And then the second problem is this use of this model of PACT and sort of community treatment that kind of follows the acute treatment and the way we do it is really not widely done. It's done, PACT is done in two groups, PACT model. It's done in some places with really wealthy folks who can pay cash for these kind of services.
Right.
We know some of those programs, right? And great, those people get great care. And you also see that it's done in some public mental health programs because some of these programs realize, oh, this actually saves us money, which it does. I
Yeah.
started a PACT
These
program.
little blips
Yeah,
of
so it's
good
like
stuff in the
I
country,
started a
right?
PACT program in Nevada and we brought people out of the hospital. We reduced recidivism. It does actually save money to do PACT programs. Is my cat distracting you?
Oh no, not at all.
Okay.
No.
So by the way, that's my meaning. I'm a foster mommy for cats. I'm a cat lady, and I'm a big believer in just say yes when it comes to fostering if you want meaning in your life. So anyway, that's my plug for one of the ways
There
I
you
get.
go.
Okay.
You're carrying
But
across the board, you know?
across the board, yeah. Yeah. Okay, so as long as it's not distracting, Todd, I'll just
Not at
not
all.
make
Please.
my cat get down. But so the one thing we talked about is this bifurcation where you've got the private high cash places doing PACT, and then you've got some hospital systems, public, like Medicaid, Medicare population doing PACT because they realize, oh, this actually saves money. People aren't going in and out of the hospital. And
Mm.
that's for the people that don't know, PACT stands for Assertive Community Treatment or Program for Assertive Community Treatment. And it's sort of this hospital without walls concept that was really derived from taking all the staff that was in a hospital and planting them in the community and doing a lot of work in the community. It started in like, I think the 70s in a public system in Wisconsin, if I'm not mistaken. But so it's this public, certain public systems have PACT and then the high cap. So what I want to do, what my hope and goal and vision is to bring this model that blends that acute phase that we're able to do with that integrated, the principles of PACT so that people are getting into their life in a meaningful way. And we've got that blended together and deliver that into the commercial space so that I can work with programs, that, where the mom or the dad is the teacher or the mom or the dad is the janitor, whatever, and they have health insurance with X payer or Y payer. So that because this model is really people with mental illness and eating disorders, they're owed a better model of care. And it shouldn't
100%.
just be if you have the cash to go pay for a PACT program, or it shouldn't just be, okay, the person is so debilitated now that they have no functional life and they're just on Medicaid and Medicare and they've ended up in the public sector and they really haven't been able to heal because they haven't ever got the care that they want. Because every one of us, like we deserve a chance. People deserve a chance to get to that essence, to get to that place where they can manifest what they're meant to be. And the integration of the PACT with the acute care is really my passion and my hope is that I can convince the payers and the commercial insurance industry that this is so beneficial that it reduces the trauma on the patient, on the family, it reduces recidivism, it makes people have better outcomes, and it
Costs less
ultimately
money.
it does cost less money. You know what? Even if it costs more, it should still be okay. But it does actually cost less because I
Right.
mean, an acute hospitalization is a crazy amount of money. Don't forget when you're doing this assertive community treatment, you're making sure they're going to their doctor appointment and getting their preventive screenings done. And so you're not just making sure the mental health is taken care of, you're making sure they're getting their pap smear, they're getting their colonoscopy and mammogram and all that preventive stuff. And you're saving money along those lines and going to the dentist, things
Yeah.
like that.
I mean, it's a very similar analogy. I I was recently in Connecticut and I was Dr. Rocky Murata was on the show recently. Dr. Andrew Gerber, CEO of Silver Hill Hospital, they
Hmm.
were doing a presentation. It was a conference. Virgil got to present at it and everything else. But they were one of the things that we ended up talking about because they did panel at the end was this subject.
Hmm.
And I said, look, insurance companies are going to save a lot more money if they just go ahead and pay for what we call, you and I would call actual care. You
Yeah.
know, long enough at all the
Right.
levels and allow a
Right.
person to progress and everything else, like pay for it.
Yeah.
And you're going to get better outcomes out of the people. Dr. Gerber turned and said, look, insurance companies are never going to do that. You're going to force them into it because the average payer, the average subscriber rather, is only stays with their company for
Exactly.
2 years. And
Yep.
I said, well, yeah, but if they all did it, then
They would all say, yeah,
they would
exactly.
all
If it
benefit.
was universal, yeah.
What is the argument? What's the argument that you would make to an insurance company with all that kind of
I mean, that whole piece of what that person said about the lifetime, like the risk to the payer is like, oh, I've got this patient, I got this subscriber for 2 years. So why should I pay for this longer length of stay, right? I would say a couple things. One is even if you pay for a longer length of stay, if these patients are getting out, 2 3 weeks into higher level or a week in the hospital, whatever, they still cost the system a lot more money because of also the medical visits. They end up in the emergency room and these patients end up having
repeatedly? Hmm.
recurrent hospitalizations a lot of the time.
The revolving
um,
door.
yeah, and then I think the other piece of it that gets really missed is the impact on the family and the people. It's like your kid has a major mental illness. Like you're not going to be at work. You're going to be calling in sick. You're going to get sick. You're going to have more. You're going to be less productive. You're going to be less happy. You're going to have your concentration is going to be impaired. So I think if payers thought about the whole system too, that would really help. Another barrier to this model is, and it's beginning to change with some payers, but when the behavioral health and the medical are split off. So
Right.
that's a big problem. So the behavioral health side is like, well, if it's saving money on the medical side, I don't get the credit for that. It's just my P&L is behavioral, and then theirs over there is the medical. So the psychiatric care saved money on the medical side, but the behavioral side didn't get any credit for that because it's a separate organization, literally, which is completely ridiculous. Um, so I think moving in the direction of these models going to be more integrated is really, really important. And you do see that more and more. And it is absolutely silly that they aren't more integrated, but it's really just the way the models were derived.
Well, it's almost like, this just occurred to me. I don't know why, but there's this dyad going on where healthcare is sickness incentivized. You know, longer a person stays in care, the longer a doctor gets paid to monitor, the longer drugs get used for that, lifetime prescriptions for, managing a medical condition. Say it's diabetes. It's like, well, you're going to be on this medication for the rest of your life. So
Mhm.
you have this healthcare system that's aimed at sickness. You know, either it's sickness incentivized or it's just we don't do anything until sickness occurs and then there's a problem and it's an emergency care kind of style system.
That's a big issue right there.
Right.
Yeah.
Then you've got the other side. You've got insurance companies that are paying for healthcare and they're denials oriented. You know
Oh
what I
my
mean?
God. Yeah.
They're trying every way they can not to pay
Yeah.
for this person's long-term
Yeah.
care or, big medical need or expensive psychiatric need in this particular case. If we could flip this script and just say, let's incentivize healthcare, let's incentivize wellness, right? So that your payers aren't in the hole on paying for long-term conditions for which there's not a lot of really good outcomes versus going ahead and paying for care people need, including preventative care, and getting far better outcomes. It's almost like the Monsters, the Monsters Inc. thing.
Yeah.
Uh, Laughter is 10 times more powerful than scream.
Mm.
Health is 10 times less expensive than sickness.
Hmm. Yeah, absolutely. I think we all have a tendency to um, sort of underreact, I think, to our own healthcare needs, right? But then it's
Right.
like break our leg, like we're going to go to the emergency room, but we might not have
Right.
thought about what, stretching or exercise or whatever that might have made us had better balance or whatever.
Yeah.
I remember you're making me remember that book, Seven Habits of Highly Effective People, and he had like the
Stephen
grid.
Covey. Yeah.
Yeah. And I don't know if you remember the grid where it was like things that are unimportant that require urgent attention and versus things that are important that don't require urgent attention. Like the things that are important that don't require urgent attention, those just like they're important, but they're not urgent. And so they just get like falling off the
Process in the
wayside.
background.
Yeah,
Right.
slows the background. So you're managing things that are urgent and important, like the broken leg, and you're also managing things that are urgent and unimportant, like checking your phone and all of this instead of taking care of yourself.
Right.
So where our priorities get really, where we put our time and how we use our time is like really important. And so I think in the insurance space, it just naturally sort of happens of like, okay, well, we just got to handle the acute stuff, but the other stuff. I do think that, when I talk to some of the insurance companies, another thing that has happened is that there's a little bit of like, I think, cynicism sometimes around mental health care because there's such a huge variability of the quality of that care.
Yeah, that's true.
And so I've talked to some of the payers who they don't want to pay for care that they don't feel is going to be effective, or they see the fact that, yeah, when you just go to residential and then you go out and then you go back, it costs them a lot of money to pay for
Yeah.
residential care that doesn't really work because the model, again, is flawed because it's lack of follow through on the other side, or the other thing that happens is, and I hate to say this, but I think to the layperson, if they have a loved one with a mental health problem or needing disorder, they're not necessarily discerning between different residential care. They're just like, my kid went to residential care, my kid went to PHP. They don't understand there's a whole bunch of different kinds of programs, different quality, different skill of the teams, like different philosophies. So the insurance payer, like the family, maybe just be like residential care and like it doesn't work
Yeah.
and the person just goes in and out,
Because I've been to three places and it didn't work. Right.
Yeah. And so
Right.
the insurance companies also get cynical too.
They
And
they they need a therapeutic consultant.
they
I if I
do.
if they decide that they when they sign on, I'm bringing you with me. We're
You
going
know what?
together.
Why don't I bring you to my next meeting with my next major? I'm going to bring you Todd. I'll be like, you know what? I wanted Todd to join my meeting to talk with you a little bit about
I'm just a guy, you know.
You're just a guy that knows what's happening out there, right?
Well, if you it's honestly, I don't think it's that hard to look at and see what the real what the problem is and what the solution is.
You
I
know
don't
what?
think this is rocket science, honestly.
I I've said this so many times. Like what we're doing is not rocket science. Like sometimes people are like, "Oh my gosh, your program's so innovative." I'm like, "This is literally common sense."
Well, I think that not to diminish what I think is a truly accomplished clinician and somebody who knows how to provide real care to people. That's a skill and an art, and let's not diminish that. But
Okay.
if we take the 10,000-foot view, we look at what the system's supposed to look like.
Yeah.
I agree.
Yeah.
It's not really all that complicated. The trick is time. We've got to
Right.
give people enough time to heal and the right modality that matches their
Correct.
condition. Those are
Absolutely.
your principles. If we can start sticking to those, we're going to get somewhere. I promise you. You know what I
I
mean? So,
agree. I couldn't agree. And then the other third thing that you said, the time, the modalities, right?
mhm.
And I'm confident you're going to agree with me, is like the quality of the human
Oh
being
yeah. Well, yeah.
that are there with the person. Those people also understanding the modalities. I have seen the higher level care system, if you will, get a lot of a beating because there has been a lot of turmoil and turnover in the space. And much of that is tied into low reimbursement because
That's right.
the
There
quality,
you
right?
go.
Quality of those. And I'm not saying that somebody with less experience is less quality because you can have a brand new person be a freaking A+ clinician. Um,
But you need
but
their investment.
yeah, but it's like people aren't going to keep. I mean, look, working in these programs, a higher level of care, it's like, you know, the machine, it's just firing, 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 firing at all times. So this is a kind of work that takes stamina and passion and conviction and all that. If people aren't getting reimbursed or, excuse me, paid for their services and, getting
Well,
raises
they're
and things
getting nickeled and dimed,
yeah,
you
and it's
know.
very difficult. And I've found that to be true myself. One of my struggles is just, hey, the cost of doing this has gone up and up and up and across all domains. And it's very hard to tell very hardworking clinicians, like, I don't have enough money to give you a raise right now. And we run into that a lot. And that's very connected with now we're talking about, again, the insurance industry, where if you really think about it, we're paying all this money to insurance companies and all of like how much of the money that we're paying and their budget is actually going to administrative functions and paying for these systems of like denying or not denying care there. It's not actually going to actual care.
Putting bonuses in executive pockets. I
Yeah,
mean,
it's not
there's
actually
that too.
paying for the therapist that's doing the therapy.
Right.
And so that's a little bit, of a predicament or a pickle. But I find personally that's something I'm going through right now is like just having so many deserving staff that I want to give more money to keep them and to incentivize them because they deserve it. But finding it difficult
Yeah.
to do that based on, what our reimbursement rates really
I
are.
don't think you're alone.
Yeah.
I don't think you're alone.
Yeah.
Um, Wendy, it has been I've had such a good time just
I
sitting here
know. Me
talking
too.
with you. It's been really great. Thanks for being on the show with me. This has been Head Inside Mental Health, broadcasting on WPVM 1037, the voice of Asheville. Dr. Wendy Oliver-Pyatt on the show. Wendy, thank you so much for being with us today, and I will look forward to seeing you when I get down to Florida here in a few
I'm
months.
so happy about that, Todd. Thank you very, very much for having me on your show. It's been a delight. I appreciate you.